Welcome back, dear students. This is a continuation of the previous lecture in which we discussed how bacterial cell wall is synthesized and what is the significance of a cell wall in the life of a bacteria. We discussed that bacterial cell wall is important because it protects the cell membrane of the bacteria from the harsh environment of the surrounding. And we said that bacterial cell wall is produced by peptidoglycan, is composed of peptidoglycan, which is composed of an acetylglucosamine attached to an acetylmuramic acid, and an acetylmuramic acid has a pentapeptide chain attached to it. These muramic acids and N-acetylglucosamine, they bind to each other for elongation of the chain, and the cross-linking between them is taking place through the pentapeptides attached to an acetylmuramic acid. So, the peptide bonds formed between them is by transpeptidation. The elongation reaction was because of the enzyme which was transglycosylase. Now, we'll be talking about cell wall synthesis inhibitors, the drugs which will be inhibiting the synthesis of cell wall. Why is that important? Whenever we intend to stop a bacterial growth or we want to kill a bacteria, we try to find out a site which is specific to the bacteria but not present in human beings. If we talk about cell wall, you all know that cell wall is present in bacterial cells, but that is absent in human beings. So if we give a drug which will go and block the synthesis of a cell wall, that will destroy your bacteria but will not have any effect, deteriorating effect on your host or human being. So this is the reason we want to use those drugs which block the synthesis of cell wall. Second important thing, that cell wall synthesis inhibitors block the synthesis of cell wall. So very important is that they will lead to disruption of the cell. This is the reason all the cell wall synthesis inhibitors are bactericidal, the drugs which will lead to the destruction or death of the bacteria. Clear? So how do we classify bacterial cell wall synthesis inhibitors? This is very important. We can classify them as penicillins, cephalosporins, or we have miscellaneous drugs, carbapenems, aztreonam, and vancomycin. Very important to remember here is that we can classify, this is according to the Kerzen, this classification is according to the Kerzen. But very important thing to remember here is that we can classify these drugs based on a ring present in their structure. This ring is named as a beta-lactam ring. All those drugs which have this ring, they are called beta-lactam antibiotics. All those drugs which lack this, all those cell wall synthesis inhibitors which lack this beta-lactam ring, we name them as non-beta-lactam antibiotics. And very important thing to remember here is that this beta-lactam ring is very important for the integrity of a beta-lactam antibiotic. If there is a problem in this beta-lactam ring, if by any means the bacteria is able to destroy this beta-lactam ring, these drugs will become ineffective for their effect. Clear? So we can classify according to this beta-lactam ring these drugs as beta-lactam antibiotics or non-beta-lactam antibiotics. Among these cell wall synthesis inhibitors, penicillins, cephalosporins, carbapenems, and aztreonam, these four groups have a beta-lactam ring and are termed as beta-lactam antibiotics. So we have classified bacterial cell wall synthesis inhibitors as beta-lactam antibiotics and non-beta-lactam antibiotics. Beta-lactam antibiotics are the antibiotics which have a ring which is a beta-lactam ring in their structure, and this beta-lactam ring is very important for the integrity of that particular antibiotic. And the other drugs which lack this beta-lactam ring are termed as non-beta-lactam antibiotics. We can have vancomycin and some other drugs we'll be talking about in a few minutes. Clear? So cell wall synthesis is very important for bacteria. If they lack a cell wall, this will lead to disruption of the cell, because the cell membrane cannot bear the harsh environment of the surrounding. And we can classify bacterial cell wall synthesis inhibitors as beta-lactam antibiotics or non-beta-lactam antibiotics based on the presence of a beta-lactam ring. The drugs which have a beta-lactam ring are termed as beta-lactam antibiotics. For example, penicillins, for example, cephalosporins, for example, carbapenems, for example, aztreonam. And the drugs which lack these beta-lactam antibiotics, they're termed as non-beta-lactam antibiotics. For example, vancomycin, fosfomycin, cyclosporine, daptomycin, and some other drugs. Clear? So we can classify cell wall synthesis inhibitors. One very important thing I will talking about is your this beta-lactam ring. The drugs which will have this beta-lactam ring in their structure will be termed as beta-lactam antibiotics. They can be either penicillins, they can either be cephalosporins, they can either be monobactams, for example, aztreonam, and they can be carbapenems. Very important thing to remember here is that all beta-lactam antibiotics have cross hypersensitivity among them. All beta-lactam antibiotics have cross hypersensitivity among them except this aztreonam. What does it mean? It means if a patient is hypersensitive to penicillin, it means it will have a cross hypersensitivity to cephalosporins as well as carbapenems, but there will be no cross hypersensitivity with aztreonam. Similarly, if a patient is hypersensitive to cephalosporins, it will have a cross hypersensitivity to penicillins and carbapenems, but no cross hypersensitivity to aztreonam. Similarly, in case of carbapenems, if a patient has hypersensitivity to carbapenems, it means this patient will have cross hypersensitivity to penicillins and cephalosporins but not to aztreonam. Clear? Then we have non-beta-lactam antibiotics. Non-beta-lactam antibiotics are the drugs which lack this beta-lactam ring. Clear? These can be vancomycin, these can be fosfomycin, bacitracin, cycloserine, daptomycin. Clear? Now, the first and very important group is beta-lactam antibiotics. And among beta-lactam antibiotics, today we'll be talking about penicillins. Penicillins, as you can see here, this is from Lippincott, that penicillins are the drugs which are derivatives of 6-aminopenicillinic acid. And very important thing is that they have a beta-lactam ring in their structure. So two important things in the structure of penicillins. First important thing, that they are derivatives of 6-aminopenicillinic acid. And second important thing is that they have a beta-lactam ring. So important to remember that this beta-lactam ring is very important for the integrity of this drug. If there is a problem with this beta-lactam ring of penicillins, they will not remain effective for their action. Clear? Then how do we classify penicillins? Penicillins can be classified as narrow spectrum penicillinase susceptible. Now what is a penicillinase enzyme? A penicillinase enzyme is an enzyme which will lead to degradation of this beta-lactam ring. Degradation of this beta-lactam ring. Penicillinase enzyme can also be named as a beta-lactamase enzyme. A beta-lactamase enzyme is an enzyme, or penicillinase enzyme is an enzyme which will lead to degradation of a beta-lactam ring. In case of penicillin G and penicillin V, which are narrow spectrum penicillinase susceptible agents, these drugs, number one, are narrow spectrum, which means they are not effective against a broad range of bacteria. They're only effective against a small range of bacteria. And second important thing, that these are penicillinase susceptible agents, which means if a bacteria is producing penicillinase enzyme, these penicillinase enzymes can lead to degradation of penicillin G and penicillin V. So whenever we will talk about penicillin G and penicillin V, we'll be saying that these are the drugs which have a narrow spectrum, and these drugs can be broken down by your enzyme, which is beta-lactamase enzyme or penicillinase enzyme. Then number two, we have very narrow spectrum but penicillinase resistant drugs. Very narrow spectrum means they're only effective against one group of bacteria. And second important thing, that they are penicillinase resistant. It means if a bacteria is producing a beta lactamase or penicillinase enzyme, these drugs will still remain effective against those drugs, against those bacteria, sorry. The examples for very narrow spectrum penicillinase resistant drugs are methicillin, neficillin, oxacillin. One of the mnemonics which can be remembered for this is M, N, and O. Methicillin, neficillin, and oxacillin. Then we have wider spectrum penicillinase susceptible drugs. It means they will be wider spectrum, which means they will not be effective against only one group, they'll be effective against a broad range of bacteria. And secondly, these drugs can be broken down by beta lactamases enzymes, which are penicillinase enzymes. So we can classify them as aminopenicillins, which have an amino group in their structure. They can be ampicillin or amoxicillin. And we can also classify them as anti-pseudomonal drugs, because pseudomonas is considered to be one of the very resistant organisms, and these penicillins are effective against pseudomonas as well. So these are termed as anti-pseudomonal drugs, for example piperacillin and tecarcillin. So we have classified cell wall synthesis inhibitors as beta-lactam antibiotics and non-beta-lactam antibiotics. Among beta-lactam antibiotics, we have classified beta-lactam antibiotics as penicillins, cephalosporins, then monobactams and carbapenems. Among them, one very important group is penicillins, and penicillins can be classified as narrow spectrum but penicillinase susceptible. Then very narrow spectrum but penicillinase resistant. And third and last, very narrow spectrum, broad spectrum or wider spectrum but penicillinase susceptible drugs. In case of your narrow spectrum with penicillinase susceptibility, we have penicillin G and penicillin V. In case of very narrow spectrum and penicillinase resistant, we have methicillin, neficillin, and oxacillin. And in case of our wider spectrum but penicillinase susceptible drugs, we have either aminopenicillins, ampicillin or amoxicillin, and we can have wider spectrum anti-pseudomonal drugs, piperacillin and tecarcillin. Clear? Coming to the pharmacokinetics of penicillins. Very important thing, that these drugs have varied bioavailability. And why a varied bioavailability? That because different penicillins have varied resistance to gastric acid. Some drugs get metabolized easily by gastric acids and some can not be metabolized easily by gastric acid. This is the reason they all have varied bioavailability. Among these drugs, parenterally we can give ampicillin, piperacillin and tecarcillin. These are the drugs which can be given through parenteral routes. Then very important, that the polar compounds are not metabolized. These are polar compounds and are not metabolized extensively. Clear? And very important, very important, that they are mostly excreted in urine in an unchanged form, and the major mechanism behind this is tubular secretion, glomerular filtration and tubular secretion. So very important that these penicillins have a varied bioavailability. There are some which have parenteral formulations. They are polar compounds and can be metabolized extensively, and very important, they are excreted in urine in an unchanged form. And in that, very important is glomerular filtration and tubular secretion. Clear? Filtration and tubular secretion. This tubular secretion can be blocked by a drug which we studied or discussed in the treatment of gout, which are uricosuric drugs, which compete with the secretion of penicillin or uric acid or methotrexate or acidic drugs at acidic transporters in the distal convoluted tubule. And thus what happens, for example, this is your if we look at here, this is your distal convoluted tubule, and here we have an acidic transporter which will lead to secretion of acidic drugs, for example uric acid, for example methotrexate, for example penicillins. Clear? If probanacid moves through this, these things cannot move through this. So whenever we give probanacid, this will block tubular secretion of your penicillins, and thus it can increase the amount and duration of action of penicillins in the body. Next, very important, these are the drugs, these mostly all the penicillins are excreted through urine in an unchanged form through glomerular filtration and your tubular secretion. But among them we have some exceptions. For example, we have neficillin and ampicillin. They both are eliminated through biliary route. So among penicillins, all are excreted through urinary route except N and A, which means neficillin and ampicillin. Neficillin and ampicillin. Everyone says we have to leave the body through urine, but two drugs say na 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 na, and those two drugs are neficillin and ampicillin. Na na. Then very important that most of the penicillins have a plasma half-life of 30 minutes to 1 hour, and procaine and benzathine forms of penicillin G. We can attach a procaine group or a benzathine group to penicillin G, and addition of these groups to a penicillin can increase the duration of action of these drugs, and then they can be given intramuscularly. Clear? So this is very important. So if we talk about the pharmacokinetics of penicillins, they have varied oral bioavailability. There can be some which have a parenteral influence. There are some which have parenteral. Let me erase all of this. Some have parenteral formulations. They are polar compounds, not metabolized extensively. They are excreted through urine unchanged, through glomerular filtration and secretion. The secretion, tubular secretion of penicillins can be decreased by the addition of probanacid. Then very important that neficillin and ampicillin, they are excreted through biliary route. They have a half-life of 30 minutes to 1 hour, and addition of benzathine or procaine group to penicillin G can increase the duration of action of these drugs, and these drugs can be given intramuscularly. Now, most penicillin, this is very important, sorry I forgot this, that most penicillins cross blood-brain barrier only when the meninges are inflamed. In my previous lectures, when I was talking about an introduction to chemotherapy, in that lecture I said that there are some drugs which can cross your blood-brain barrier easily. There are some drugs which cannot cross your blood-brain barrier, and there are some drugs which can cross your blood-brain barrier when the meninges are inflamed. In a normal situation, they cannot cross your blood-brain barrier, and penicillins are mostly the drugs which cannot cross your blood-brain barrier even when the meninges are inflamed. Clear? Then, very important, the mechanism of action of penicillins. They say first important step is binding to a penicillin binding protein. On the cell membranes of the bacteria, we have a membrane to which these drugs go and bind. The beta-lactam antibiotics, all the beta-lactam antibiotics have same mechanism of action. All of them go and bind to a protein on the cell membrane, which is a penicillin binding protein. After binding to penicillin binding protein, they inhibit an enzyme which is transpeptidase enzyme. Previously, we talked about this enzyme, that this transpeptidase enzyme is important for transpeptidation, which is important for cross-linking. This transpeptidase enzyme is blocked by beta-lactam antibiotics. And the third mechanism which is involved is production of autolytic enzymes. Autolytic enzymes means the enzymes which can lead to autolysis of those bacterial cells. So first important, step is binding to penicillin binding protein present on the cell membrane. Second step is inhibition of transpeptidase enzyme or transpeptidation. And third important is activation of autolytic enzymes. If we see this in a diagram, we can see that this is your cell membrane or cytoplasmic membrane. On the cytoplasmic membrane, we have different penicillin binding proteins. The beta-lactam antibiotics come and bind to this penicillin binding protein, and thus ultimately will lead to inhibition of this cell wall synthesis by blocking transpeptidation reaction. Here, two mechanisms are very important. Number one is these porins, which are important for the entry of the drug into the cell. Number one. Number two, this penicillin binding protein. And number three, this enzyme beta-lactamase. These three important mechanisms are present here, which we can see. A bacteria can acquire resistance against a drug either by decreasing permeability of these porins or by making a change in the structure of penicillin binding protein or by the production of beta-lactamase enzyme. These beta-lactamase enzymes will lead to destruction of beta-lactam antibiotics. Clear? So this transpeptidation reaction can also be seen, the mechanism of action can also be seen here. That in the previous lecture we said that we have a complex which is N-acetylglucosamine, N-acetylmuramic acid, and a pentapeptide chain attached to it. And there was a transpeptidase reaction. For example, this is a transpeptidase enzyme. In the presence of this transpeptidase enzyme, there was transpeptidation between two muramic acid. Look at the heart, which is a transpeptidase enzyme. This is going here and leading to a transpeptidation reaction. This leads to cross-linking. I've already talked about cross-linking. Why is it important? Yes, this is important for the integrity and strength of the cell wall. When we give a beta-lactam antibiotic to a person, to a host, what will it do? It will go and bind to this transpeptidase enzyme and will block it. What will happen when transpeptidase reaction will be blocked? There will be no cross-linking. No cross-linking. Whenever there is no cross-linking, what will happen? Yes, there will be decreased integrity and strength of the cell wall. What will happen ultimately? There will be a decreased covering over your cell membrane, and this cell membrane can be destroyed by the harsh environment of the surrounding. Clear? This is another way in which they have shown that this is N-acetylglucosamine and muramic acid. To this muramic acid, a pentapeptide is attached, and this transpeptidase reaction can be blocked by giving penicillins or other beta-lactam antibiotics. Clear? Then we have now the different groups of penicillins. First important group is narrow spectrum but penicillinase susceptible agents. It means these drugs, I've already told you that these drugs will have a narrow spectrum and they will be susceptible to the activity of beta-lactamase or penicillinase enzyme, which means their beta-lactam ring, this beta-lactam ring will be destroyed by penicillinase enzyme. Clear? We have penicillin G and penicillin V. Among them, penicillin G, these drugs are susceptible to beta-lactamase enzymes, as we've already noticed, discussed. Then, second important thing, that they are having a limited spectrum. Limited spectrum means only one group or maximum two group of bacteria. For example, in case of these drugs, these drugs are effective against streptococci, meningococci, gram-positive bacilli, and spirochetes only. So these have a limited spectrum, and thus we can say that these drugs are having a narrow spectrum. And because they are susceptible to beta-lactamase enzymes or penicillinase enzymes, this is the reason we name them as narrow spectrum penicillinase susceptible agents. Clear? Then we have another important thing. Now, this is a very important university question. Which of the drug is the drug of choice? Drug of choice. Whenever we'll be talking about different drugs in chemotherapy, very important is to remember the drug of choice for a particular bacteria or a disease. The drug of choice for the treatment of syphilis, drug of choice for the treatment of syphilis is benzathine, penicillin G. Very important. Never ever forget this. Why? Because it's an important question. Important university question. Many of the times it is being asked in the exam, which of the following is the drug of choice for the treatment of a patient with syphilis? And the answer to this question is penicillin G. Benzathine penicillin G. Primary and secondary syphilis. Now, there can be a question. You're very happy. Yes, Dr. Muneeb said the drug of choice for the treatment of syphilis is benzathine penicillin G. There is a scenario. A patient comes to you who is suffering from syphilis, primary or secondary syphilis. What should be the drug of choice for that patient? Yes. Answer is benzathine penicillin G. But what if in this scenario they say the patient is unfortunately hypersensitive to beta-lactam antibiotics or penicillins? Obviously, there is a big no for any beta-lactam antibiotic except monobactams. But monobactams are not effective against syphilis. Then what can be the possible alternative drugs which can be used for the treatment of syphilis? They can either be tetracyclines or spectinomycin or ciprofloxacin or ofloxacin. Clear? Tetracycline, then we have spectinomycin, ciprofloxacin or ofloxacin. TCSO. TCS, we have a courier company here in Pakistan. Tetracyclines, ciprofloxacin, spectinomycin and ofloxacin can be used as an alternative drug for the treatment of syphilis if the patient is not able to tolerate benzathine penicillin G, or the patient is hypersensitive to benzathine penicillin G or beta-lactam antibiotics. Then next point is that many strains of pneumococci are now resistant to penicillins. So penicillinase resistant pneumococci, and how are they producing that resistance? By the production of enzyme which is penicillinase. Clear? Then most strains of Staph aureus and Neisseria gonorrhea. Most strains of Staph aureus and Neisseria gonorrhea, they're also resistant against these drugs because of the production of beta-lactamases or penicillinase enzyme. Then activity against enterococci is enhanced by aminoglycoside antibiotics. We'll be talking about protein sense inhibitors in the upcoming lectures, in which we'll see that when we give two bactericidal drugs, they have a synergistic effect. They increase the activity of each other. So in this scenario, the enterococci activity against enterococci is enhanced by the addition of aminoglycoside. Clear? Then penicillin V. Penicillin V is an oral drug used mainly in oropharyngeal infections. In case of oropharyngeal infections, we can use penicillin V. Then our next group is what is the antimicrobial spectrum of penicillin G? Here you can see that they are effective against gram-positive cocci, for example, Streptococcus pneumoniae, for example, Streptococcus pyogenes, for example, Streptococcus viridans, which means all the streptococci. Then they are also effective against gram-positive bacilli, for example, Bacillus anthrax, for example, Corynebacterium diphtheria. But remember, the drug of choice for the treatment of Corynebacterium diphtheria is erythromycin. These drugs can be used or we can say are effective against our Corynebacterium diphtheria, but the drug of choice for Corynebacterium diphtheria is erythromycin. Please do remember. Please do remember. By now we have talked about two drug of choices. First drug of choice against syphilis, which is benzathine penicillin G. Second drug of choice against your Corynebacterium diphtheria, which is erythromycin. Clear? Then gram-negative cocci, Neisseria gonorrhea, and Neisseria meningitis. As we already mentioned here, that resistance against these many of the bacteria is also emerging here. Then anaerobic organisms, we have Clostridium perfringens. Then we have Spirochetes, Treponema pallidum, and Treponema pertinue. And among them here, syphilis is caused by Treponema pallidum, against which these benzathine penicillin G is the drug of choice. Is the drug of choice. Clear? Please remember this. Then very narrow spectrum penicillinase resistant drugs. So they'll be having a very narrow spectrum, which means they'll be effective only against one group of bacteria. And the second thing is that they will be penicillinase resistant drugs. For example, if a bacteria is, creating a resistance against a drug by the production of penicillinase enzyme, these drugs will be effective against those bacteria because they are penicillinase resistant drugs. For example, we previously said that they are MNO, which means in methicillin, neficillin, and oxacillin. Clear? So methicillin, which is the prototype is not the best drug. It's the first drug to be established, to be available in the market. Then we have neficillin, then we have oxacillin. These are the three drugs: methicillin, neficillin, and oxacillin, which are very narrow spectrum penicillinase resistant drugs. They are penicillinase resistant, and they are involved in the treatment of known or suspected cases of staphylococcal infections, Staph aureus and Staph epidermidis. Penicillin G is effective against Staphylococcus aureus, but because of the production of beta-lactamase enzyme, these penicillins are not effective against your penicillin G is not effective against your Staphylococcus aureus. In those patients in which there is a resistance against penicillin G by the production of beta-lactamase enzyme, our methicillin, neficillin, and oxacillin are effective against those Staphylococcus aureus. Clear? So if a bacteria changes its penicillin binding protein, structure of penicillin binding protein as a mechanism of resistance, then these drugs will not be effective against those bacteria, Staph aureus, which means Staph aureus can generate resistance against methicillin, neficillin, or oxacillin by changing penicillin binding protein, by mutations in penicillin binding protein. Clear? And those bacteria which are resistant to this group of drugs, those Staph aureus are termed as methicillin resistant Staph aureus, MRSA. Some of the people name it as MRSA. This is MRSA, methicillin resistant Staph aureus, which means those Staph aureus which are resistant to methicillin, neficillin, or oxacillin because of the mutation or change in the structure of penicillin binding protein. Which means because there is a change in the structure of penicillin binding protein, it means none of the beta-lactam antibiotics can destroy MRSA. Clear? Very important. So, methicillin resistant staphylococci and methicillin resistant enterococci by changes in Staphylococcus aureus and Staphylococcus epidermidis strains are being produced by changes in penicillin binding protein. Remember this thing? Clear? Then wider spectrum penicillinase susceptible drugs, they will have a wider spectrum, which means they'll be effective against gram positive and gram negative bacteria, and these drugs will be penicillinase susceptible. The previous penicillins, which were very narrow spectrum, they were resistant to penicillinase enzyme, but the wider spectrum group here is sensitive or susceptible to penicillinase enzyme or beta-lactamase enzyme. For example, we have aminopenicillins, which is ampicillin and amoxicillin. These are susceptible to penicillinase, as we already discussed. They have a wider spectrum than penicillin G. Why? Because they are wider spectrum antibiotics. They are effective against gram positive and gram negative organisms. Then indications. The indications of aminopenicillins are same as that of penicillin G, but in addition to them, they're also effective against a wide range of gram negative bacteria. So now this very important thing, ampicillin against Listeria monocytogenes. Drug of choice for Listeria monocytogenes infection. Monocytogenes infection is ampicillin. Please do remember. Drug of choice for the treatment of syphilis? Yes? Yes. Benzathine, penicillin G. Drug of choice for the treatment of Corynebacterium diphtheria? Yes, 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 come on. Yes, this is erythromycin. And the drug of choice for the treatment of Listeria monocytogenes is? Yes, you are absolutely right. This is your ampicillin. Clear? Please don't forget about these drug of choices. Then these drugs are also effective against Enterococci, E. coli, Proteus mirabilis, H. influenza, and Moraxella catarrhalis, most of the gram-negative organisms. Penicillinase inhibitors enhance their antibacterial activity. We'll be talking about later in the continuation of these lectures regarding the penicillinase inhibitors, the drugs which inhibit those penicillinase enzymes. And we'll see how these penicillinase inhibitor enzymes will block the activity of beta-lactamase enzymes and thus increase the sensitivity of drugs to those resistant organisms. Then ampicillin is synergistic with aminoglycosides in enterococcal and listeria infections. Once again, the same thing that aminopenicillins, ampicillin is a bactericidal drug, aminoglycoside, a protein sensor inhibitor, is a bactericidal drug, and both the bactericidal drugs, when they will be given together, they'll have a synergistic effect and will have an effect which will lead to a greater effect as compared to the previous one. Clear? Then talking about our next is antimicrobial spectrum of aminopenicillins. Antimicrobial spectrum, they are effective against gram-positive cocci, for example, enterococci. They are effective against gram-positive bacilli, Listeria monocytogenes, and they're also effective against a wide range of gram-negative rods or bacilli, E. coli, H. influenza, Proteus mirabilis, and Salmonella typhi. So they have a wider spectrum as compared to penicillin G. They have a same spectrum as penicillin G, but in addition to that, they have a wider spectrum compared to wider wider gram-negative coverage as compared to your penicillin G. Clear? Then we have wider spectrum penicillinase susceptible drugs. For example, we have anti-pseudomonal drugs. The rest of the penicillins, they were not effective against Pseudomonas, gram-negative organisms. They are very tough to destroy, very tough to kill. So these wider spectrum penicillinase susceptible drugs, they're termed as anti-Pseudomonal penicillins because in addition to other gram-positive and gram-negative bacteria, they're also effective against Pseudomonas. So we have piperacillin and ticarcillin in this group, susceptible to penicillinase. They have activity against gram-negative rods, for example, Pseudomonas, Enterobacter, and Klebsiella. They have once again they have synergistic actions with aminoglycosides. Once again, the same thing. Two bactericidal drugs given together will have a synergistic effect. Enhanced activity when used with penicillinase inhibitors, once again because they are susceptible to penicillinase enzyme can lead to destruction of these drugs. If we give these drugs with the drugs which are inhibitors of penicillinase or beta-lactamase enzyme, what will happen? They will enhance the activity of these drugs. Clear? So by now what we have studied, we have talked about penicillins, which are derivatives of 6-amino penicillin acid. They are beta-lactam antibiotics. Beta-lactam ring is very important in their structure. Then we have talked about pharmacokinetics, that oral bioavailability is varied. We have different parental formulations. Most of them are excreted mainly in urine in an unchanged form, either both by glomerular filtration and tubular secretion. And this tubular secretion of penicillins can be blocked or decreased by the use of propanacid. Then we said that ampicillin and your nephicillin, these are the two penicillins which are not excreted through urine, they are excreted through your biliary route. And then we talked about the mechanism of action of these drugs, that penicillins can, number one, they bind to a penicillin binding protein. Number two, they lead to inhibition of transpeptidation reaction. Number three, they lead to the activation of autolytic enzymes. Then we classified penicillins as narrow spectrum, penicillin is susceptible, for example, penicillin G, penicillin V. Then very narrow spectrum, but beta-lactamase or penicillinase resistant drugs, for example, methicillin, nephicillin, oxacillin. Then we talked about our very broad spectrum or wider spectrum penicillinase susceptible drugs, for example, aminopenicillins, ampicillin and amoxicillin, and our anti-pseudomonal drugs, for example, piperacillin and ticarcillin. Clear? Coming to the spectrum, the drug of choice for the treatment of syphilis is benzathine penicillin G. Otherwise, they are active against streptococci and pneumococci. Then we talked about our very narrow spectrum penicillinase resistant. They are effective against Staphylococcus aureus and Staphylococcus epidermidis. If we have a patient who has Staph aureus infection, first choice is penicillin G. If there is production of beta-lactamase enzyme and Staph aureus is having a resistance against those drugs, then the second choice, then the drug of choice in those scenarios is either methicillin, nephicillin, and oxacillin. Among them, methicillin is the prototype, but because of its higher nephrotoxicity, interstitial nephritis, this is not being used. We can use nephicillin or oxacillin for the treatment. Clear? Third thing important, if there is a bacteria which is leading to a change in the structure of penicillin binding protein, a Staph aureus which is leading to a change or mutation in the structure of penicillin binding protein, this will lead to a resistance against your methicillin, nephicillin or oxacillin. We term them as methicillin resistant Staph aureus. Clear? Then we have wider spectrum penicillin susceptible, aminopenicillins, ampicillin and amoxicillin. They have a wider spectrum. They have a spectrum similar to penicillin G, but a wider spectrum against gram-negative bacteria. Among the aminopenicillins, ampicillin is one of the drugs which is the drug of choice for the treatment of infections caused by Listeria monocytogenes. Clear? And the wider spectrum penicillinase susceptible drugs, we have anti-pseudomonal penicillins, which are piperacillin and ticarcillin. They are effective against a broad range of gram-negative bacteria, and among them, one of them is your Pseudomonas. Two synergistic mechanisms have been seen here. One, synergism with the use of aminoglycosides, because penicillins are bactericidal drugs and your aminoglycosides are bactericidal drugs. They both have synergistic effect, and then use of these penicillins, beta-lactamase sensitive or susceptible penicillins with penicillinase resistant penicillinase inhibitors or beta-lactamase inhibitor drugs, there is an enhancement in the activity of those drugs. Now, the antimicrobial spectrum of anti-pseudomonal, they have a wider activity against gram-negative rods, Enterobacter, E. coli, Proteus mirabilis, Proteus indole positive, H. influenza, and Pseudomonas aeruginosa. Most important thing to remember here is that they are effective against Pseudomonas aeruginosa. Clear? Then resistance mechanisms. Penicillins can generate resistance by the production of beta-lactamase enzymes, or we name them as penicillinase enzymes. For example, Staphylococcus and many gram-negative bacteria can generate resistance against beta-lactam antibiotics by the destruction of beta-lactam ring. How is this beta-lactam ring destroyed? By the production of beta-lactamase enzymes. Number two, there can be a structural change in penicillin binding protein. As we all know, that beta-lactam antibiotics, for their mechanism of action, the first step is their binding to penicillin binding protein. If there is a problem in this penicillin binding protein, your beta-lactam antibiotics cannot bind to this penicillin binding protein. So, if there is a change in the structure, there is a mutation in the structure of penicillin binding protein, what will happen? The drugs, the beta-lactam antibiotics will not be able to bind to that protein on the cell membrane, and thus there will be no action. So, which drugs show this resistance? Methicillin resistant Staph aureus, MRSA, or penicillin resistant streptococcus, PRSP, or penicillin G in pneumococci, resistance to penicillin G in pneumococci. And enterococci can also show this sort of resistance against beta-lactam antibiotics. Then changes in porine structures, as we've already seen in a previous diagram, that gram-negative rods have a porine for the entrance of drug. If there is a decreased permeability, there is a decreased permeability in the porins, decreased entry of drug into the cell of the bacteria, decreased chances or decreased activity of the antibacterial drug. So then what are the benefits of using penicillins with penicillinase inhibitors? These penicillinase inhibitors, these will be the drugs which will be blocking your beta-lactamase enzyme, or they'll be blocking your penicillinase enzyme, and thus, for example, clavulanic acid, sulbactam, tazobactam, these are the drugs which are penicillinase or beta-lactamase inhibitors. When we give these drugs to a patient, in addition to penicillinase susceptible drugs, these drugs can enhance their activity against those resistant bacteria which have produced resistance against these drugs by the production of penicillinase enzyme. Clear? So if penicillins are combined to these drugs, their antibacterial activity is enhanced against penicillinase producing bacteria. Clear? Then what are the possible adverse effects of penicillins? Very important is hypersensitivity or allergic reactions. Please do remember, whenever you are working in emergency, whenever you are working in a clinical setting, please do remember this thing, that always give a test dose before administering an antibiotic. What is a test dose before administering a drug? We inject subcutaneously some of the drug and then check for any hypersensitivity reaction. If the patient has no hypersensitivity reaction to that particular drug, then we can inject that drug to the patient. Please, one of the take home messages: test dose for antibiotics. Test dose for antibiotics, please. Otherwise, patient can have urticaria, patient can have allergic reactions ranging from simple urticaria to anaphylactic shock. This can be so lethal. That the patient can die. Clear? Please Always give a test dose before administering an antibiotic. Allergic reactions can be urticaria, joint swelling, interstitial nephritis in case of methicillin. This is the reason methicillin is not being used nowadays. Then severe pruritus can happen, hemolytic anemia, and neutropenia in case of nephicillin. And the you know weirdest thing which can happen by a simple penicillin, the safest drug in pregnancy, is anaphylactic shock. Please, please, please test dose. Test dose, give a test dose to the patient before administering any antibiotic. Clear? Then cross allergenicity is very important. As I have already told you, whenever we talk about our beta-lactam antibiotics, it is very important to remember that beta-lactam antibiotics have cross hypersensitivity among each other except monobactams. If a patient is hypersensitive to penicillin, there is 100% hypersensitivity for other penicillins. There is 5% cross allergenicity with cephalosporin. So if a patient is hypersensitive to your penicillins, there are 5% chances that the patient will be hypersensitive to cephalosporins as well. But please remember, if a patient has an anaphylactic shock with the penicillins, never, ever, never, ever use a cephalosporin in that patient. Never ever use a cephalosporin in that patient. Please. Also, cross allergenicity with carbapenems, one of the other beta-lactam antibiotics, but no cross allergenicity with astrinab. No cross allergenicity. So, cross allergenicity, number one is allergic reactions. Number two, cross allergenicity with all the other beta-lactam antibiotics except your monobactams, for example, astrinab. Clear? Then GI adverse effects, nausea and diarrhea, and very important that ampicillin can cause overgrowth of Clostridium difficile, because it's a broad spectrum antibiotic. This will lead to pseudo membranous colitis. Whenever we give a broad spectrum antibiotic to a patient, all the normal flora is killed. Previously, there was a competition for the nutrition between the normal flora and Clostridium difficile. When we give a broad spectrum antibiotic, all the normal flora is dead. Now there is no competition for nutrition between Clostridium difficile and the normal flora, and all the nutrition is taken by your Clostridium difficile, and this will lead to an overgrowth of Clostridium difficile, leading to what? Leading to overgrowth of Clostridium difficile and a disease and the condition which is pseudo membranous colitis, which means there will be a false membrane will be formed in your colon. Pseudo membranous colitis. A false membrane is formed, and colitis means there will be inflammation of your colon. Clear? Please do remember this thing. Ampicillin is one of the penicillins which can lead to your pseudomembranous colitis, which is a super added infection. Clear? And what is the drug of choice for this pseudomembranous colitis? That is metronidazole. The drug which we use in our daily life, which is Flagyl, that contains an active principle which is metronidazole. The generic name is metronidazole, and the drug of choice for pseudomembranous colitis is metronidazole. So in today's lecture, what we have studied, we have talked about the classification of cell wall synthesis inhibitors. We have talked about the classification of penicillins, which are the beta-lactam antibiotics. We have talked about very narrow spectrum, and wider spectrum penicillins. And then we have talked about their antibacterial spectrums, and in the end we've talked about adverse effects of penicillins. We have talked about 4 drug of choices. Number 1, drug of choice for syphilis. Please, yes, you're right. This is benzathine penicillin G. Number 2, the drug of choice for the treatment of your infections of Listeria monocytogenes. Yes, come on, please. Yes, you're right. This is Listeria monocytogenes. Number 3, the drug of choice for the treatment of your pseudomembranous colitis. Yes, please. You are absolutely right. This is metronidazole. And number four, and the last one, drug of choice for the treatment of, I am unable to remember. Yes, for Corynebacterium diphtheria. Drug of choice for Corynebacterium diphtheria. Yes, yes, you're absolutely right. This is erythromycin. With this, I end this lecture on penicillins. We'll be talking about cephalosporins in our upcoming lectures. Hopefully, you'll understand this thing, this lecture, and we'll be talking about cephalosporin and we'll be revising some of the penicillins in our upcoming lecture. Thank you very much.